So we'll get started with the next session where we are going to speak about surgical guides and why surgical guide. So this is how a surgical guide would appear. The one advantage with the use of surgical guide is the predictability. Once you design the guide, if your design and the surgical planning is all perfect, then it is the most predictable outcome. So with the guide, you have predictable outcome. There are no risks of complication because you've already assessed all the major assessments that are required in terms of the anatomic regions that are needed, and then only you've done the planning, so there are going to be low risk of complication. And because it is a prosthetically driven surgical planning, you're going to have optimal aesthetic outcomes as well. So with that of a guide, the major advantages are that you have patient safety, it is highly predictable, very accurate in terms of the accuracy. Because you're not going to open a flap, you're going to have less bleeding, less complications in terms of that. Because there is a guide, the time for surgery is also going to be less, so the dentist or the person who's doing the surgery is also going to be more confident about it. Like I said, the surgical time is going to be extremely less compared to a conventional placement. It is going to be a flapless surgery and your patient is going to go back with less pain and is going to be more happier. The only reason that could act as a drawback is going to be the expense associated with the guide and the printing of the guide and the drilling kit, and the initial curve, which is there with all the processes, that there is a learning curve to it, so it is going to be slightly technique sensitive. So surgical guides initially, they had different generations, and the current surgical guide that we are working with, or the current workflow in terms of surgical guide, is going to be a 5th generation wherein we are going fully digital. So we take a CT, we combine it with the oral scan, and then we make a 3D guided stent. So for a successful guided placement, what we require is a CBCT, from where we get the diacom of the bone that is there, and the STL, that is of your upper and the lower arch, and then the combination of both is what will lead us to our guide. So the workflow is going to be that step 1 is going to be your CBCT collection, your step 2 is going to be your intraoral scans or your impressions, your step 3 is going to be the merging of these two data, your step 4 is going to be the surgical planning on the software, step 5 is the guide designing, step 6 is going to be the prosthetic components, and step 7 is going to be the execution of the surgery. So coming to the step 1, the data collection for CBCT is one. Yeah, so data collection of CBCT is going to be the first parameter that we are going to do. We've spoken in depth about CBCT and the necessity for it yesterday. So we're going to go ahead with the requirement for the CBCT, and major requirement is going to be that there should be no blurring, no distortion, and medium resolution has to be there. Only if you have a CBCT with a good quality will you have the resulting processes easier. So these are the steps that you can avoid to avoid movement blur, wherein you position your patient accordingly, make sure that the CBCT from the oral medicine side comes out properly. Then we move ahead to the second stage of the planning, which is going to be your data collection. Now the data collection can be from two ways. The most predictable way is an intraoral scanner, because the scan, the STL that is there intraorally, is what is going to depict in your STL in the designing software. So if there are going to be any errors when you take an impression or when you pour a cast out of that impression and that has air bubbles or it has certain inclusions, and then you're going to take a scan out of it, designing a guide on top of that may lead to certain errors in the fit or the final planning of the guide. So it is always recommended to go ahead with an intraoral scanning than compared to a lab scan of the casts that are available. Again, we've spoken in depth about intraoral scanners yesterday and the different available intraoral scanners. So I'm going to skip through that aspect. So this is how we continue with the intraoral scanning. So with the intraoral scanning again, you take a scan of the upper and the lower arch, and you make sure that the scan doesn't have any inclusions or extra stitches that get added one top of the other. Any corrections that are required, we do it at the scanning level only. So if there's any areas that have not come out properly, you cut out and rescan those regions again. With this, I'm going to skip through this video because it's a walkthrough of how an intraoral scan needs to be taken. Our next thing is going to be the merging of the data, which is your DICOM and the STL. So the DICOM comes from your CBCT and the STL is generated from your intraoral scan. So this step happens in your implant planning software, wherein you load in your CBCT as well as the STL, and based on these certain anatomic features, your DICOM and your STL get connected to one another. So this is one example of the same, where the DICOM and the STL have got connected to have merged with each other, and then we go ahead with implant planning. So the software on itself will have different libraries of available, commercially available implant systems, and it will also have library to go ahead with the prosthetic planning of the same. So post the merging of this, you go ahead with the surgical design. Now surgical guide design can again be of two types. One is a static system and one is a dynamic system. With this in terms of surgical guidance. So your static system is going to be like a map, which is your guide, the guide that we print. That will tell you exactly where you have to go. But in terms of navigation or navigation softwares, those are going to be your dynamic navigation systems or dynamically guided systems with which it is like a GPS. It will tell you to go left, go right, and it is very, very technique sensitive, and it has a steep learning curve, so it takes some time to get used to the navigation system. Coming to the types of guides that we have. So we have three types of guides that you can go ahead and design. One is a tooth supported guide, a tissue supported guide, and a bone supported guide. So when we talk about the tooth supported guide, they have the best fit because they go and get adapted onto the available tooth surface. The merging of the files are easier because you have a lot of anatomic structures, you have the cusps, you have the fossas that you can use to merge your CBCT as well as your STL files. The planning is going to be more easier, and the patient's movement has to be restricted during the scanning phase. Next, we move on to the tissue level guide. So with the tissue level guide, for us to continue with the tissue level guide, you need a dual scan technique. So the dual scan is when you take a STL file and you merge it with that of the denture. In dual scan, when we talk about dual scan technique, this is more so important for completely edentulous patients, wherein you make a complete denture beforehand and then you continue with your planning of the implants. So what you have to do in a dual scan technique is you take a CBCT of the patient and then you create markers onto your upper and your lower denture. You either place composite markers or you place zirconia markers on the same, and then you take a CBCT of the dentures as well. So the dentures are going to be in the patient's mouth as well. There is going to be a CBCT of that, and then there is going to be a separate CBCT of your upper and the lower denture, and that is called your dual scan protocol, with which you will merge everything together and then go ahead with your tissue level planning. Then we come to the bone supported guides. In this, it will require a full flap elevation. Only a DICOM file is required for the same, and there may be variation between the 3D mapping that is there. Coming to the final part of it, the last to second part of it, which is going to be a prosthetic component. So once your implant planning is done, you can then merge the STL from the implant planning to that of your designing software, the 3Shape designing software, and then you can go ahead and plan the prosthesis even before you place an implant. So that amount of predictability is what is achieved in terms of placing a guided implant or going ahead with a guided surgery. Once the prosthetic components are also ready, then this is how the digital data set would appear. So you would have your CBCT or a DICOM file, you would have your virtual implant in it, you will have your virtual abutment, then you will have your prosthetic, you will have your intraoral scan as well, and then you will have your prosthetic component on top of it. Once the implant planning is done, then certain companies like Dio, one being one of them, they give their own digital planning protocol, wherein they will provide you the drilling sequence as well, and they will tell you at what speed, at how your bone is, what is the sequence of the drill that you need to use for the particular type of bone quality of the CBCT that you have provided. On the day of the execution of the surgery, you will have the guide all ready, and then you can go ahead and place the final implants. So this is a short demonstration of how you can do an implant studio planning in terms of 3Shape. So this is how the system would appear, wherein you can go ahead and do the surgical guide planning. You go ahead and you load where you want to place the implant, where you want to start doing the planning. In this case, we are doing it in the lower arch, 3-6 and 3-7 region. So you go ahead and mark your implants in that particular region. Once that is done, then you import your scans into the system. So like I said, 3Shape will guide you at all points of time what the next step has to be. Once the files are loaded, this is the STL file, then we load the DICOM. You can slice the DICOM accordingly. Any additional scans that you would like to add at this point can be done at this. Now since we are going to do the prosthetic designing, we add the antagonist as well. This is an immediate implant case, so we are getting rid of doing a virtual extraction, doing the extraction of the 3-6 and 3-7, the area that we intend to place the implant. Because we are going to do a prosthetically driven surgical planning, you again set the occlusal plane. Just how with the convention, with the complete denture, we do a 3-point occlusal plane analysis. Once the occlusal plane is set, then this is where our prosthetics would also play in. So even before you plan your implant position, you finish the planning for your prosthesis, and that's why it's a prosthetically driven surgical planning. So there are chances of very minimal errors. The cases that happen with your freehand placement, wherein you get your access channel way buccal or way lingual, the chances of those errors happening with a digital planning are going to be very minimal. You set the curve for the panoramic view. Once you're happy with everything, then we go ahead and now we do the scan alignment. Now this step we align the STL with that of the DICOM. This step is very important because any error here will lead to errors in the fitting of the guide that we are planning. And that in case will in turn affect our implant position, then our prosthesis delivery also. So this is the nerve marking because we are going to do a planning in the lower. So it will ask you to trace the nerve from the opening, from the exit point. So once you trace the nerve, the system itself has a certain set of safety standards from the anatomic structures. So the minute you go somewhere close to the anatomic structures, it will prompt you that you are close to the anatomic structure and you have to maintain a safety distance of 2 mm from these anatomic structures. So if you see, there are 2 lines that appear on the DICOM. One is that of the STL as well. So this superimposition has to be checked everywhere. Once you're happy with the superimposition, then you go to the implant library based on the plan that you have or the system that is available. You go ahead and place that particular system's implant onto the bone and you check, like I said, on close proximity to the nerve. It will not allow you to go to the next step. It will keep prompting red alert. Once you place an implant to check for parallelism, there are certain designing aspects in that as well, where you can place 2 implants perfectly parallel to each other in the planning. At this point, you can increase the width or decrease the width of the implant, increase the length of the implant, change the angulation. This is for 2 implants in the posteriors, but all on 4 planning, zygoma planning, which we'll be discussing further, can all be done with the help of this software. Now we reassess with that of the prosthesis. We see a screw channel axis right in the center. You assess your DICOM and STL merging together. You assess the central axis channel opening. So with this, your biomechanics of the implant are also safer and the outcomes and chances of failure are going to be much lesser. Then we move ahead to the guide creation. So in this, you You just have to mark an outline or boundary of the guide till where the extent of the guide has to be. Since this is a tooth supported guide, you take 3 teeth ahead of that to stabilize the guide onto the tooth areas. Once you mark the extent, you create a guide on top of the teeth that are there. And you can provide these reference windows so that during the surgery, as soon as you place the guide onto the tooth structure, with the help of a probe, you can check the fit of the guide onto the tooth structure. This is a customization, so you're printing multiple guides in a day. This is just a patient and a doctor customization that is there. And post the planning is done, the system generates a surgical report like this, wherein you can see the bone quality, you can see how much the bone implant contact is going to be. Now going ahead with the surgical guide during considerations, this is how the guide would appear, and this is the cross section of the guide on the tooth. So only if the guide is sitting onto the tooth surface and adapting perfectly, will the implant placement and the further prosthetic part of it go according to the plan. If there are going to be any errors during the placement, then it is going to lead to errors in your implant placement and errors in your prosthetics as well. One very important thing in planning, and then while continuing with the drilling or placement of the sleeve, is something called as the offset. Something that is really confusing, but once understood is a very easy concept. So the offset value is nothing but your distance from the fixture level to that of the soft tissue, as well as the sleeve that are provided in the guide kit. So that distance is going to be your offset value. When we are doing a conventional implant placement, your drills are going to be, see if I am placing an implant of 10 mm, my drill height I will go only till 10 mm. But what happens with the drill or with a guided surgery is that you're going to have your guide, you're going to have your soft tissue, you're going to have the thickness of your guide, and you're going to have the blue rings that you see, those are the sleeves that are available. So you're going to have the thickness of the soft tissue as well as the sleeve. So if I were to place a 10 mm implant, I cannot just stop with the 10 mm drill. I will have to have the length to compensate and to make them, but because my offset value, the distance of my soft tissue and the offset, the sleeve is going to be different. So my implant driving in is also going to be of different dimensions. And if you're doing a prosthetic planning, then it is very important that you match your abutment to that of the implant fixture. There are certain markings or indications that are available on these implants, and those it is always better to have on the buccal aspect for the ease of visibility, number one, and for the ease of matching your abutments or the prosthetic components with that of the implant in future also. Because you will do the surgery today, then you will be doing maybe the delay, if you're going to do a delayed loading. If your markings are going to be somewhere in the distal or the lingual aspect, to keep matching the prosthetic components to that of the implant are going to be a tedious task at that point of time. Now we move on to the different case scenarios. So the first case that we have here is of a gentleman who had come with us of anesthetic appearance of his upper teeth, and when we had seen they were severely periodontally compromised, so what we had planned was a quad zygoma in relation to his upper arch. So when we started, this is how the planning, once you finish the planning on the software, you can get a sheet like this which will tell you how much the bone implant contact is, what is going to be the amount of bone that is available, the quality of bone that is available. So you have a D1 bone, D2 bone, D3 bone or a D4 bone. And in such scenarios, it is more easier for you to understand whether you have to undertake an osteotomy side or go to the full training sequence for the same. So once that is done, in this case we went ahead. So this is how we arrange everything in our OT. We have our pre-operative pictures of the patient, and then we have the drilling sequence that is there, and we have the implant planning, so that at any point you want to go back and refer to anything, it is much easier for us to do the same. In this case, we went fully digital, wherein we planned although the implants were placed freehand, but we went with the digital part for the prosthetic planning. So what we've done here is, there is something called as a fiducial marker. So this marker on the palette that you see, a silver color marking, that helps us in reorienting the different scans that we take during the procedure of the implant placement to the prosthetic components. So what we do is place this fiducial marker even before we start anything, even before we open the flap or extract the teeth. We place this fiducial marker and then we go ahead and take an intraoral scan. So this set of my intraoral scan is going to be my preoperative scan. Once this set is done, So ma'am, this one was created by the student in our college. This is made of metal. We 3D printed into pattern resin, and then we invested it and cast it into metal. So there are different prototypes like that are available. But the main point of this fiducial marker is that it can be made in pattern resin as well, or it can be made in wax and then cast into metal. It is similar to that of an implant only or a metal structure, just that it goes into the palate and acts like a reference point. So this needs to have certain dimensions that my system can take and can merge all the remaining files, because this is just one file that I am showing you now.
This has to be in place
Till the end of the, correct.
So
The internal scan.
place if you are in the palette, you have it will have
Sorry.
you're saying this has to be in place before
Correct.
you take the scan. Right? Intraoral scan.
Correct.
So, and you have made this to be positioned on the palette.
Correct. It can be in terms of maxilla, it can be placed on the palate. In terms of a mandible.
Stay on there.
So it has threads, ma'am. It's like a small screw, like how ortho has mini implants, mini screws. The design, yes, we screw it into the palate.
So
In
you
terms of,
use a mini implant for that as well?
you could use a mini implant, but the problem with mini implant is that it won't have structures that can be easily read by the software. So this would make, if you see there are certain rectangles that are jutting out, it's like a star pattern. So this pattern, my system can easily reach when I'm trying, now this is one scan, but by the end of our prosthetic, when we reach the prosthetic part, we will have a total of 4 or 5 scans that need to be merged together. So with the ortho screw, what is going to happen is it's going to be a shiny surface, and every time I scan it and try to reorient, my scanner may not be able to, or my designing software may not be able to adapt it onto each other. So we came up with this design wherein we have these struts that are jutting out from the center, so that my scanner can easily read those struts, because once we place it into the palate, then we are not going to move this till the end of the prosthetic part. So this is going to be a stable reference point. This will only be removed after we finish our final prosthesis delivery, or once the final design of the prosthesis is gone for milling or printing.
So you are printing this in 3D, like using this.
Yes, we designed this on freeform software, which allows you to design anything and everything. So it is a software to design any 3D object. So we came up with this design on that, and then we printed the resin that we showed you yesterday, the green resin. So we printed this prototype in that, just to check the dimensions and how it looked. Once we, because this also took us 4 or 5 designs to come up to this particular pattern that is there here. So once we are happy with the final design, then we went ahead cast it in metal. So this is cast in metal right now, and then we put it into the patient mark. So same sequence that we
That you cast in metal would have
threads. Correct. It would have threads to go into the palate, or in terms of the mandible, because once the teeth are, in this case we have the teeth also as a reference, but in terms of completely edentulous, where there is soft tissue, the scanner would not read. That is what we discussed yesterday, that is why in terms of digital planning for a complete denture also, you cannot start with an intraoral scan right away, because the soft tissue will keep reflecting the light. And because of the saliva that is also there, it is very difficult, and going completely guided requires a high level of accuracy, because even one step goes wrong, then the fit of the entire prosthesis is going to get damaged because of it. So that's why we came up with this. So in terms of the mandible, you can place this on the retromolar pad also, because they're going to be away from the surgical side and they're not going to hamper any other area of our surgical requirement. But during scanning, we can extend the scanner to the retromolar pad, so that will act like my reference point for planning the lower as well. So in maxilla, this is the preoperative scan. Once we take hold of this preoperative scan, so this is how the scanning was done in the OT. So we place the reference point, completed the preoperative scan. This is the, now we finished the surgery. So we've extracted the teeth according to our surgical plan, go on ahead and place the implants, place the multi-units also. So next, if you see, we have placed scan bodies. So there are 4 scan bodies that are there on the upper arch, and now we go ahead and take a scan of this. So my marker stays in position. I go ahead and take the scan body, I take a scan with the scan body so that I get the exact implant position as well. And then my next step is going to be the removal of the scan bodies to take a scan of the gingiva that is there. Because for me to design the prosthesis, I would also need how the gingival architecture is. So then we go ahead and take a scan of the gingival architecture that is there. So by now we have a total of 3 scans that needs to be merged. So if you were to use, like I said, an ortho screw or screw of a very shiny surface or without any modules or sheet to it would become very difficult to mark a point and to provide reference to the system that this is the position that you have to go and snap back into. So this is the one with the gingiva, wherein we've removed the scan bodies and just taken the scan with the gingival architecture. Now there are certain links that we have to show you of how the merging takes place on the designing software.
Till Dr. Kushali setting up the videos, I'll just give an elaborate thing about the pin. So the pin is an existing science already. So it's a reference pin. You can make it in multiple shapes you want. Just that it should be in multiple dimensions, which means it should have more reference areas. That's one thing. So what you do for the patient when the patient comes in first, this is the clinical protocol. Step one will be
So this protocol you mean to say is for any implant guided,
when you want to temporize as soon as you finish your case. Any surgical type fabrication that you can do and keep. But when the patient comes first, step one, what you do is you take the intraoral scan. Now you're not using any pin. So as the patient comes in, you're taking your scans. Second day, when you go to surgery, when you anesthetize the patient, anesthetize the palatal area also, which you will by default be doing for a full mouth case or a sectional case. And then we drive this thread into the mid-palatine raphe for the upper. The screws on it is just 2 millimeters. So it's not going to surpass the palatal area, it's just going to stay firm in the palatal area. So as soon as the screw is placed, you do a second scan. So first scan is only the existing teeth if there are any teeth. If there are no teeth, if it's a completely edgeless patient, we make a CD, we put a slight hole in the palatal area for the screw to fit. So that will be the pre-op scan. Then on the day of surgery, with the pin and the CD, or with the pin or the existing dentition itself. Okay, if the patient is dentate and existing dentition, the pin before we start the surgery. Anesthesia, put the screw, take a scan. So we have scan 1, scan 2. Scan 1 has teeth. Scan 1 has teeth plus the pin. Now post surgery, there are no teeth because you've extracted, considering a full mouth case or whatever, but the pin is still there.
So this is only applicable for complete.
You can do for long segments because for short segments, scanners will take up by default. You don't have to struggle so hard for this. Only when complete full mouth cases and big segments, you might have to do this. So now you have 3 scans. Scan 1 is pre-op, scan 2 is pre-op teeth and pin. Scan 3 is implants placed and pin. So in the first scan, that is a pre-op scan, you can do a mock designing, like you do for smile designing, anything. Like you can just do a physical wax up, a digital wax up. But this digital wax up, if you print and keep ahead, and during the surgery, if there's a 1 millimeter difference, then your prosthesis will not go and fit directly. But since you have the digital design, don't print it, don't mill it, just keep the design ready and scan 1. Scan 2 is with the pin and the existing teeth. Scan 3 is the pin and the implants. Now these 3 scans can merge, that is you want to essentially merge scan 1 to scan 3. And the pin is common in the second 2 scans, the teeth are common in the first 2 scans. So obviously scan 1 and scan 3 will merge. Now whatever design you have made and kept the template of the design in the scan 1 because it's pre-operative. You just have to modify depending on your implant positions that are currently placed at that point. Because any pre-milled restorations, even if it's off by a 1 degree or a 2 degree, the screw will not threaten. That's something that we all accept. So it's better to, so with the advantages, you're using very less time because you have a pre-designed set of design. You are just connecting it to the implants and sending it to print or mill directly. So that milling or printing process will take about 2 to 1.5 hours. You'll be able to deliver the restoration before the patient even wakes up from GA. So that is the advantage.
Will single fiducial marker suffice for a
For upper,
completely
yes.
endless,
For upper, yes. For upper, yes. Lower, you need at least 2 because
two
yeah.
are required.
Lower we do 2 or 3, one in the midline, two in retromolar areas. Upper one is more than enough, because when you scan the upper arch, the rugae, the pattern of the arch form itself is scanned very easily. So people who have been using the scanners, you will understand that upper scans are easy. You will be able to get everything in the upper scan very easily. So one marker is more than enough. And since that one marker has a lot of projections, there is no way that it's not going to go and reorient, because it will go and reorient in that one specific.
So like what sir explained now, this is one file where we merged the data that was available. So we have a pre-op scan with the JR of the patient. Then we moved ahead and went and now because the markers are there, so I can easily use that as a reference point in my designing software. I can assign points to it stating that this is the stable reference point, this is where I want the STL to go and merge to.
And all this you're doing in Plant Studio?
No ma'am, this is on the designing software. Implant Studio is only for implant planning and generating a surgical guide. But if you're, sorry ma'am, this is ExoCAD. Only ExoCAD will allow this level of workflow. This level of workflow in 3Shape is a little difficult to work with because the addition of scans in 3Shape is slightly difficult. Like I said, it's a nice workplace, but it's slightly restrictive. So it will only allow you a certain degree of freedom, whereas ExoCAD allows you full freedom to do anything and everything with the available software. So here now we are merging the implant, the scan bodies, so I get the implant position. And then we merge the soft tissue architecture so that we can go ahead with the prosthetic planning. So if you see, each and every point is marked, and then the STL is there, it goes and merges. So if you see on the left hand side, it says a total of, where I am moving my pointer, there are multiple scans that are here. So you have a jaw scan, then you have a gingiva scan, then you have a scan abutment, then you have a pre-op scan, then you have pre-op with printed material. So all this is only allowed in terms of ExoCAD and designing in relation to ExoCAD. So this is how the merging of the file takes place. Once the files are merged, and then to move ahead with the prosthetic planning, this is the workflow for the same. So we have the scan of the gingival architecture, then we have the antikinous teeth that are present, and we go ahead and just how we design a crown and bridge, we go ahead and use the implants and mark the margins and go ahead with the design of the crown and the bridge. So we have the tooth component as well as the gingival component in this region. This is how the implant positions are, just to verify the access channels that are there. You can then merge it with that of the pre-op scan as well to assess how the teeth were pre-operative and how much difference we are going to make with the prosthesis that is going to be there. Assess the occlusion. Now the planned prosthesis for this is an I-bar with a superstructure on top of it. So then this design, once we do a draft trial in the patient, if time permits, we do a draft trial in the patient's mouth. And then this goes into blender wherein the separation takes place between the teeth as well as the gingiva. So because this was intended for an I-bar and a superstructure, this would have been the workflow. If we were to go ahead with a mallow bridge in a similar case, a similar situation, the workflow till now would have been the same. However, the prosthetic part would change and this is how it would follow. So this we have a scan of the gingival architecture. Then we superimpose it to the scan of the scan bodies. This will provide me the exact implant position that is there. Then we go ahead and with the library that is available on the software, plan the prosthesis that is to be designed. These are the access channels. So we go ahead and just how we do the crown and bridge fabrication, we do the same way. But in terms of mallow, you will have a gingival component and then you will have the primary abutments or primary tooth position. So this is how it is going to be. Once we generate the crown and bridge, then we do a cutback. So it is going to be an overall cutback similar to how a natural tooth would be after we prepare it. So we do a cutback and then it appears like abutments. So this is how the abutments are going to be post the cutback. Once you get the mallow ready, so this is going to be a primary framework. This can again be milled or can be cast in metal, and then on top of this is where your copings or the crowns are going to be designed. Post the framework trial of this is when the crowns and the copings will get designed. So this is one more example for a process that could be given for a full mouth. Then we have our conventional hybrid denture, wherein the bar fabrication for the same. So this is also another option that is available that can be designed using the software. So these are retentive, roughen the surface so that the retention and adherence with acrylic is much better because of the roughened surface. And this is where the tooth position would be, the final tooth position in terms with that of the bar. And this is how the prosthetic component could move ahead. This is another example of a bar that is there, wherein we have retentive slots again prepared to better adhere of the, for providing better adherence of the PMMA or the acrylic on top of it. This is to assess the implant position. Once you take a scan with the scan body, you can feed in the particular implant that has been used in the patient's mouth, and then that appears in the planning as well. So then we go ahead, finish the planning, create a bar with the retentive slots. Moving back to the case, so this is how we had gone ahead. We made the bar and then we went ahead with the draft trial. There were certain changes that were to be made in the draft trial. So once the draft trial changes were made, then we went ahead with the milling of the final PMMA prosthesis. Once the final PMMA prosthesis were milled, this is how it would look. So the PMMA would require some amount of characterization. That can be done with indirect composites, and this is how the final prosthesis was delivered with indirect composite layering to mimic the gingiva. Now moving on to a full mouth zygoma. This is another patient who had visited us with who was completely edentulous, who had to be completely edentulous because of the issues with the teeth. So we went ahead, planned for zygoma placements all on four on the upper as well as the lower, and placed the multi-units. This is how the multi-units look like. We took impressions for the same. We went ahead with the conventional impression wherein we splinted all the implants together, took a conventional impression for the upper and the lower arch, and then went ahead and designed a mallow framework for him. So in this, once the GR was done, that GR with the upper and the lower casts, the STL of the upper and the lower casts again goes into the designing software. In the designing software, again in terms of the upper and the lower arch, you go ahead and similar to the crown and bridge prosthesis, the only addition here is going to be the gingival aspect. So addition of the gingival aspect, then you go ahead and you provide the mallow framework. So the mallow, once the mallow framework's assessment and fit is checked intraorally, then the same design is again scanned and the final prostheses are designed on the rescan model. So in this scenario, if there were reference points, it would be very easy to merge the initial files and then to go ahead with the designing of the same. So this is how the copings on top of the mallow would look like. This we again superimpose with that of the picture of the patient to assess how the smile line was and how the aesthetics would look on the patient even before we could go ahead with the milling of the final prosthesis. Once that was done, this is the mallow framework trial. Once we were happy with the fit of the upper and the lower trial, we went ahead, took a radiograph, assessed the margins for the same in the radiograph as well. Then we went ahead, did the smile designing picture that I showed you. These are the reference points for it. So we take the interpupillary line, we take the inner corners of the eye, the middle of the eye and the outer corners of the eye, and same for the lid. We went ahead, did a denture prosthesis also, because to assess for a mallow framework, it is always better to have a complete denture as a reference marking. So this was a complete denture to assess the aesthetics and for the smile line. We did a draft trial for the final crowns onto the mallow as well. Because he was a patient of a younger age and had high aesthetic demands, we went ahead and did multiple rounds of draft trials until the patient and we were satisfied with the aesthetics. Once that was done, we went ahead and did a final trial with the printable resin. After this trial, then we went ahead with another round of draft trial. And this is how the final crowns look like. So this was the zirconia with the final crowns. If you see the mallow framework on top, this is titanium based, so no layering can be done on the same. The characterization for this will again be done with indirect composite. So with indirect composite, this is how the final prosthesis would look like. And this is the patient with the mallow framework. So this is another option for a completely edentulous patient and the workflow for the same. Now we are moving ahead with full arch. Now these are all freehand placements, but the prosthetic planning of it. Now we are moving ahead with full arch guided placement with immediate temporization. So this patient was completely edentulous, wherein the upper and lower arch. We went ahead with the planning, and this is how the planning comes out. So for every tooth, it will give you a drilling sequence. For every tooth, based on the bone quality that is there, it will tell you that you have to under drill or you have to go to the full length. What is the offset value? What is the drill length that you have to take? What is the drill width you have to take? So if you just blindly follow if your planning is perfect and then you just blindly follow the drilling protocol that is given, it is going to be 100% predictable outcome. So the drilling kit for every system is going to be different for a guided placement. So this is in terms of a DO guided drill kit. So we stabilize the upper and the lower guide onto the arches with the stabilizing pins. Only if your guide is stable and doesn't rock on the tissue can the surgery go on smoothly. So stabilizing the guide is one of the utmost important points. Once that is done, then we go ahead with the tissue punch for the upper and lower arch. This is how a guide would look like in terms of a DO implant system. And this is the workflow that we have. So the placement for a conventional edentulous case would take somewhere around 1.5 hours. But with the guided, it would hardly take 10 to 15 minutes to complete the entire arch. So then we go ahead, do the tissue punch, irrigate nicely, go ahead with the drilling sequence. Because the offset values are already done, we finally go ahead and place the implant. We drive it down, assess the final torque. Sat for the lower again. This is our all tissue supported guide. So the system also has drill tubes for the drills that are of narrower diameters, 2 mm drills which could slip within the drilling area. They provide a drill tube so that your drill goes and sits snugly into it and then you can continue with your drilling sequence. So the major success with this is that there is no flap opening, so there is less time with it, there is less bleeding, there is going to be less complication. Patient is going to have very minimal pain because we are not going full-fledged into the bone and we are only opening and assessing the areas, going ahead with the osteotomy in the areas where we have planned for the implant. So this is the workflow for the same. This is the multi-unit placement for the same patient. Once that is done, then we went ahead and took a scan for the same and designed a set of upper and lower temporaries. And this is how the temporaries looked in the patient's mouth. So these were immediately loaded, that is on the day of the surgery or within 2 to 3 days of the surgery, the loading takes place. Next we move on to indirect sinus lift with that of immediate loading. So the planning for direct sinus lift, indirect sinus lift, yesterday as we had discussed, during the surgical planning only, it will help you in assessing the anatomic structures also that are there. So any complications that you need to avoid in terms of the arteries that are there near the sinus, any antral vessels that you need to bypass and go ahead, any nerve positioning where you want to go lingual, plan lingually or plan slightly more buccally, all that can be done with the planning. And before you even start with the placement, you are well sorted that these complications are avoided and then you can go ahead. So this is another case of indirect sinus lift with immediate loading wherein the patient had a missing 2/6. So we went ahead and did the planning for 2/6. If you see, the designing software itself tell you that the sleeve offset of 9 mm is planned. So then you keep in mind that that is the amount of compensation you would require while drilling your sequences, as well as while driving your implant into the osteotomy site. So we went ahead, did the planning for the same, and this is how the final would look like. So sinus drill would go till 16 mm. One important thing with that of the offset value is the mouth opening. So during a conventional placement, to place a 10 mm implant, if my drill would be, I would go ahead and drill only till 10 mm, and my drill lengths are going to be slightly smaller, so the mouth opening is not going to be an issue. In terms of guided surgery, one thing that needs to be focused on is also the mouth opening of the patient, because the larger the length of the implant that you're going to choose, and if the offset value is also going to be larger, then it is going to be a slightly difficult to access the osteotomy site with a larger drill. So then the patient's mouth opening also has to be sufficient enough for us to accommodate the drill and to go ahead with the drilling sequence. So this is how the final plan would look like. This is the drill sequence that would be provided. So this is the entire workflow wherein what drill to be used. Because this is going to be a sinus lift as well, it tells us that at this point the saline has to be injected and this much of saline needs to be injected, because this is a hydraulic lift. So this is how the drilling sequence would look like. This is the drill kit. These are the different offset values. So we had pre-planned the processes as well. So this is a stock apartment with the pre-planned processes. We go ahead, place the guide. This was a tooth supported guide. So we go ahead, place the guide, create a punch or a tissue cut. Go ahead and do the sinus lift. This is the hydraulic pump where we inject saline so that the sinus lining or the Schneiderian membrane slowly gets lifted up. Once that is done, then we pack the remaining area with osteograft or BIOS, the available autograft, or mix it with autograft and then place the bone graft there. Once that is done, we go ahead with the final implant placement. So on the right, if you could appreciate, we've done a lift and there's a nice room that is around the implant. That means the sinus wall is also well lifted, the graft is also well within the place, and then we've gone ahead and placed the implant. We go ahead and place a pre-milled abutment on the same and then the crown, and that is the drilling sequence. This we have a video of the design that was done. So we go ahead, place the implant, assess. This is what we had taken CBCT post the placement, and then we had merged with our planning to assess if there were any certain degree of error or certain movement in the implant placement that had happened. And as you can see, there is very minimal distortion that is present between the planning as well as the placement of the implant. This is a case of a single posterior implant with that of an immediate loading. Again, this is a case where a tooth supported guide was planned. The sleeve offset here was decided as 9 mm. This is how the planning software would look like, where you would start with the planning, place the implant in the planned position, do the prosthetic planning as well. Once that is done, this would be the drilling sequence that is there. You have the abutment and the crown that is pre-ready. The picture on the upper right is a jig. So it is a placement jig for the abutment that is there, which will aid in placing of the abutment in the desired or the planned position that was done during the planning. Same issue, we go ahead, same workflow, we go ahead with the guide placement, assess the fit of the guide, go ahead with the tissue cut, go ahead with the drilling sequence, place the implant in the position. Like I said, this is a jig to place the abutment. So this will help in placing the abutment right in the proper position. So go ahead and place the abutment in the proper position. Assess the fit of the abutment in the implant. Once the fit is evaluated, go ahead and place the crown for the same. This is another case of a posterior implant placement with that of immediate loading. This patient again walked in with edentulous region in relation to her lower posteriors. So we planned on placing 2 implants in 3.6 as well as 3.7. So we went ahead, did a digital planning for the same. If you see, there is a curvature of the bone there. So all this can be easily assessed while planning, and the planning can go ahead in a process to avoid any complication for the same. If you were to go blinded in a scenario like this, and no matter how careful we would be to avoid the lingual curvature, if there was any error during the drilling and analyzing the angulation of the implant, we could go and perforate the bone in that region. This is something that can be easily avoided with a guided placement or with a digital planning, because you well advanced know that these are the complications, and with planning in a certain way like this, I can avoid these complications. So again we go ahead, place the guide, assess the fit of the guide, do a tissue punch. This is what I was speaking about earlier, that this is something called as a drill tube. So for a 2 mm drill, if you see the access hole that is there, to go ahead and place a 2 mm drill in this, it would slip in any direction. So to avoid the slippage of the burr or the drill into the guide that we have is why we have a drill tube. So my 2 mm drill would snugly go and fit only into the hole that is there into the drill tube, and there would be no chance of any slippage that would occur if this drill tube would not be present. Then we go ahead, place the implants, go ahead and place the milled abutments, and have the final processes ready. Go ahead and place the final process in position, and these are the radiographs for the same. And this is how the planning and the post-op CBCT is. So if you see, there is a very minimal deviation from the planned placement to the from the planned implant position to the actual implant position. And this is something that is not achievable if we go blinded and don't go guided. So the next case is going to be an implant supported bridge with immediate loading. Again, this patient came in with the chief complaint of missing teeth. We analyzed the bone, and this is a scenario for implant supported bridge. So we planned on placing implants in 4-5 and 4-7. We went ahead, did a digital planning for the same, did a prosthetic planning for the same, and transferred it, got the milled abutments ready. This is the drilling protocol for 4-5, and this is the drilling protocol for 4-7. Again, the guide is printed. We have a jig that is also printed to place our milled abutment into the exact position that was planned. We go ahead, place the guide, do the tissue punch cut, go ahead and do the drilling sequence, place the implant. Now in this, if you see, we have extended the guide to the opposite side of the arch. So with the guide wherein we are placing a distal extension, a case scenario that would require a guide to be made in a distal extension, it is always better to have a cross arch stabilization of the guide to provide better fit of the guide and to provide a support part for the same. Because if this is not provided, then there are chances, because of the distal extension and the resiliency of the tissue, the guide would keep rocking, and then you would have to hold it with one hand, go ahead with your drilling, and that would compromise on the implant placement. So it is always better in distal extension cases to have a cross arch stabilization that is supported with a bar in your guide design itself. So once that is done, we went ahead, placed the implants, placed the pre-milled abutments, and this is how the final crowns looked. This is the radiograph for the same, the fit for the pre-milled abutments. And now we move on to the next case of an upper posterior implant with immediate loading. So the drilling for the upper and the lower, maxilla is most commonly the porous bone when compared to mandible. So sometimes when we go blinded, when we don't use a guide, we assess based on how we continue with the drilling. Say I finish my first drill, then I assess, okay, the bone is slightly softer, so I will under drill. Okay, the bone is of a denser quality, so I will go till the full length. So that chance of variability is always there as a clinician. But with guided, if you see, they have given exact drilling sequence. Say for a 2 mm, you go ahead with a 2 mm drill first of till 5 mm length, then you go till 11.5 with the same drill, then you take a 2.7 mm drill, you go till 5 mm length, 8 mm length and 11.5. So unlike our conventional placements, wherein if we were to go ahead with the same case in a conventional manner, I would do a placement of 2 into 5 mm drill, then directly go to 2.7 into 8.5, 2.7 or 2.7 into 10 mm drill. Either the drills would be length specific or they would be width specific or the length in a particular implant system. However, the drill kit, these will all be given separately, the drills would be separate, and it is because it is a restricted area and because the saline and irrigations don't take place properly in the osteotomy site is why the length and the width specifications are given during the drilling of the sequence. So again, we have the guide ready and we have the jig ready for placement of the prosthesis. We go ahead, place the guide, do a tissue punch cut, do the drilling sequence, place the implant, place the pre-mill abutment and temporize it. Now I will just show you a design workflow for how the custom abutments are made. design of how the pre-milled abutments can be made. So we have the scan of the healing abutment. Once that scan is there, then we have a scan with the scan body. Go ahead and do a crown designing. Once the design is ready, and you are happy with the crown position and the crown placements, then you go ahead, and this is how your pre-milled abutment, the blank would look like. So you place the pre-milled abutment blank, and then there is a cutout option in the designing software itself. You go ahead and do the cutout option. It will give you a pre-milled abutment which will be ready. So this design can then be loaded and your pre-milled abutment can then be milled accordingly. The pre-milled abutment blank can then be milled according to the design. So this is one workflow. So with the planning, once we generate the STL for the planning, that can be transferred to the designing software. In the designing software, now this was a case wherein a healing abutment was already placed, but in scenarios where the planning is already done, then the STL can be transferred to a designing software, and the same pattern with the designing of the pre-milled abutment can be carried out. So this is another example of an anterior abutment that is done. We went ahead, this is the designing for the crown on top of it. So with ExoCAD, you have an additional option of marking the gingival contour. Once your gingival contour is marked, the chances of collapse during that of the process wherein you don't have a gingival contour that is marked is very, very minimal. So once you mark the gingival contour onto the system, it will generate the crown right from the implant and will maintain the gingival contour with the design. So once the gingival contour is marked, this is how the crown would appear. You place the crown, you change the angulations according to the aesthetics and the functional demands. This again is similar to how a crown would be designed on that of a natural tooth. Once this is done, then we merge it to that of the gingival contour that is marked. So at this point, if I want to make any corrections to the gingival contour, if I want to increase or decrease the height, increase or decrease the width of the gingival contour, it can all be designed and done. So to provide the papillary collapse, the gingival contour of the crown is designed in a certain manner. Once this design is achieved, then we go ahead with the merging of the crown. So once that is done, we go ahead and make the corrections to the contour. And once the crown is placed, then we go ahead and give the option for a milled abutment. So like I said, you would already have your pre-milled abutment blank. Once you give the option to cut back, it will cut back into the exact shape of the abutment that we have designed based on the anatomic crown design that was there. So once that is done, any corrections in terms of the length or the width of the abutment can be carried out at this point. On the appearance of the margin, the aesthetics, the final abutment position, all that can be assessed. Once it is done, then if you see, this aspect is already made by the company in the pre-milled blank. So during milling, this will go into the structure that is there, and then only the top portion will get milled. The final smoothing of all the structures. Once that is done, then this file gets saved as an STL, and this goes to your nesting, and then your pre-milled abutments get milled. So now we can go ahead and maybe do a demonstration of the guides that are there. Any questions so far? We are open to questions as well.
Like in this, we are not milling the connection, is it?
Sorry?
Like we are not milling the connection in it.
No, the connection will already pre-milled will be from the company. So this is, the blank is going to be, is what we showed you yesterday, so that it is going to be the implant connection will already be pre-milled by the company. We don't generally prefer a direct connection going into the implant because then it compromises the fit into the implant and then the biomechanics also associated with it. So we like to, like we had already mentioned yesterday, if the abutments are not of the range that you want them to be in terms of the position, then you can exchange them with the company to a pre-milled abutment blank. So they will provide you with a blank. So the connection, the connection that goes into the implant will already be made by the company. So the fit is not going to be compromised, and that you can be worry-free with regards to it. What we were showing you is the designing for the abutment on top of it, because the case scenarios that we showed you all had pre-milled abutments. So this is only possible if you do a complete planning beforehand. So if you planned your implant position, then you go ahead, do the designing of the pre-milled abutment, and based on the abutment, then you design the crown. So all this is done even before your patient walks in for the surgery, and you have everything ready. So the day the patient walks into your surgery, you place the guide, you anesthetize the patient, assess the fit of the guide, place the guide, do a tissue punch, do the drilling sequence, place the implant. So this, for placement of one implant, would hardly take 5 to 7 minutes. Once the implant is into position, then you go ahead for a milled abutment like this. It is all, no matter the markings that are there on the implant and no matter how careful you are with the placement of the implant also, chance of things going wrong are always there. So it is always better to have a transfer jig, is what we had showed you. So that is printed again. So you take a transfer jig and you position the abutment into the implant. Then you tighten the abutment into the position, you check the radiographic fit for the same, whether everything is fine or not. Because now the connection is company made, the chances of error or the chances of any damage happening to the implant surface are going at close to nothing. So then you go ahead and place a crown on top of it and temporize the patient.
Yesterday also we discussed the same.
Pre-milled abutment?
About the pre-mill, yes.
We spoke about the materials.
So as far as the blanks go, the pre-mills fit directly into the same blank holder, similar to your Emax blocks. So those blocks you can use in your machine. So instead of getting a straight abutment from the company, you don't have to spend extra for pre-mill. That's what I'm trying to tell you. So the only different expense here is the milling process. And but the machine is in-house already, and you have the drills. It's grinding in the among the back system that you have. So So instead of getting a straight abutment for your implant, get a pre-milled block. So that way you can customize it any way you want. Instead of loading a big chunky tooth on a small thin stump, that is a regular abutment that you get, your abutment itself will look like a prepared tooth which you can customize with your machines in house. So we have a case file from here itself. So Dr. Kushari will be explaining about the digital planning for this. So we insist on all PG cases or anyone who does the implants to please generate a design beforehand going into your surgery, because designs are not, you may not take an output. So if you have a limited number of saves, at least let them get hang of the design. If you are exporting it as a guide file or an STL, then each export is one save. But as far as you don't export it, you can keep deleting the designs and redesignings continuously. So that's one thing we recommend for all postgrads to do.
Oh, is there any particular problems that are being faced while designing a particular guide, or so if required I can speak more in terms of that?
I think you can generally discuss the overview because we just started with it, and what we can do is probably discuss some of the cases that also, and during that discussion we can probably ask.
Okay. So this,
So in this case, the implants are planned here. Okay, so we have marked implants on all these. So is this a plan for upper full arch or just 1516? Okay. Because in this the order form is filled for 161546, but the surgical guide we've gone ahead and marked from 16 to 27. So I'm gonna just fill it all. So if we are planning just the upper jaw, 15 and 16, so I would choose the upper jaw. Then select the guide flow. So under guide flow, you have the tooth supported, bone supported, and a dual scan protocol. Your tooth supported guide is something that we would be looking forward here, wherein we will be placing implants in 15 and 16 region, and then we will take support from say the 13, 14, and 17. In a scenario, if this was a distal extension case, like I said previously, we would be extending the guide till the contralateral arch and cross stabilizing to avoid the rocking. It's similar to an RPD, like how in a distal extension RPD case we would want a cross arch stabilization. Similarly, with a guide also we would want the same. So in this scenario, we would go ahead and place a.
So for a tissue supported, we'll use a dual scan protocol.
yes, for a tissue supported, you will go ahead and you will use a dual scan protocol. But that is for a completely edentulous patient. Say you have an upper or a lower arch completely edentulous patient, you will go ahead with a dual scan protocol, considering your complete denture fits perfectly and there are no irregularities in the denture. If that is the scenario, you will go ahead and take a wash impression of the denture and then you code that as a model and then take a scan with that. Or you reline the denture and then you go ahead with your dual scan protocol. Because correct, the denture fit has to be perfect. Only then can you progress with the dual scan protocol. Because if there are going to be any errors in the fitting of the denture, then the tissue surface where your denture has to go, where your guide has to go sit, will also come up with errors. And no matter what, you will end up figuring out where the problem is. We will consider thinking that the problem is in the designing, whereas the problem was in the first step only, that the denture never fit in the first place. So from there, everything went wrong. So in that scenario, you either take a wash impression or you reline the denture, make the denture fit perfectly, and then you go ahead with the dual scan protocol. So in this scenario, it's going to be a tooth supported guide. We select the implant, so we are placing an implant in 15 and 16. Once these are done, if you're going to plan on the crowns, will come on its own. Because like I said, with a guided or understanding the surgical aspect also, it will not progress until it is not satisfied with the prosthetic plan. Only if your crown positions are placed properly, will the software let you go to the point where you can place the implant and go ahead with the implant planning. So then we save this and we move ahead. So now I'm only going to show the planning for 15 and 16. And as we can see, the implant plan is for 15, 16 and the surgical guide is also going to be generated for 15, 16. The extent of the guide can be designed while designing. We don't have to mark it right here at this point of time. So once that is done, if at all we need any additional scans that need to be added, they all get added here. Any case instructions or any images that need to be attached, that can all be done here. So we will be importing scans. Now that I see that already the scans are imported, I'm going to let the scene be there. So we go ahead and click OK with it, and then we go ahead with the next step. Because the scans are already imported, now we come here to this. So because we are going to place implants in 1.5 and 1.6, these teeth are already extracted from here.
Can we undo this and redo this?
Yes. So I think these are root stumps in relation to 1.5, 1.6 and 2.5, 2.6. And the planning, now since we filled the order form for 1.5 and 1.6, I go ahead and show for 1.5, 1.6. But it's a similar pattern for 2.5 and 2.6 as well. So in the order form only you create the order form is the first step. So only if your first step is properly filled, we can go to the next step. In order to fill the first step properly, the patient planning and the diagnostics and the planning has to be top notch before we even start with the order form filling. So once we finish that, then we go ahead, and this is where these are the two tooth removal that we want to go ahead with. So we go ahead here and draw the outline.
How do we see?
The plus option here. So like I said, in three shape, you just go put your cursor there, it will tell you add cutout line, draw a line around the tooth that needs to be removed. So there is absolutely no way that a person can go wrong in terms of three shape, because the only thing that you have to do is keep meddling around and doing, understanding what the system requires, and then just it will guide us very easily as to what needs to be done. Whereas this in terms of exoplan is a thing that you should know already. If you were to open exoplan and start working, then by then you should, in the system you should already know, okay, plus sign, where is the plus sign, where can I get the pen marker, start marking the line. In terms of three shape, it will handheld you till the very end and tell you what needs to be done. So we go ahead, mark the outline of the tooth that we want to extract. And in all scenarios in terms of designing, you come and end at the same point that you started, you double click it, is only when that one loop gets cut. Now at this point, if I want to make any other corrections to the line, I can do those corrections. I can increase the width or decrease the width accordingly. Say I want to go all the way here, then I can do that. Same way for 1.6, again we go ahead, take the plus sign and go ahead and contour around the root stump that is present. Come back to the same point, double click. So like I said, it will show you the error. So even 0.1 or 0.2 mm I was encroaching into the adjacent area, it prompted me that no, this is not how it can work out. You will have to go back and reposition it again. So once we are happy with this, with the tooth removal, we go on to the next step, which is your CBCT. So at this point, the larger the CBCT, the more the storage is going to be, and more difficult with the increasing amount of cases and the storage that the system will already have, it will slow down your system. So at this point, you can increase or reduce the dimensions that are there. Now, since we are working only with the upper arch, I am removing the lower arch entirely, and at this point, I can check the slices that I want. Now, you would be designing in relation to 2.5 and 2.6 also for same, so this window would work. So I'm just continuing with this. But if we were to go ahead with just 1.5, 1.6 and to increase the speed of the work process, I would even shorten this window here, so that we are only focusing on 1.5, 1.6 and our target area is only restricted to 1.5, 1.6. So this is the panoramic curve wherein just how we open a CBCT and load the CBCT and assess the curve. This is how we assess the curvature here, and any changes that are required can all be done here. Our target area is going to be 1.5 and 1.6 region, so which are very clearly visible. So we go ahead and we will be continuing with this only. So I'm going to go ahead. Sorry? Alter the curve, you can just move the points. You can just move the point, or you can increase or decrease this depth and the field. Now restricted to 1516, you're going to move in this direction, but you can make changes here. Actually, when you roll the mouse here, the slices from the maxilla, the sinus, it should all move. I'm not sure why it is not happening here.
Next step.
Because maybe this is already marked as why it's happening. Coming back to the occlusal plane, so this step would also mark the occlusal plane. Now as you see, the occlusal plane that was previously marked is derailed. So if I were to design my crown based on this, the system would give me crowns way below here because of the can that is present with the plane. Then I'll have to sit all the way minus the restorative material that is provided on the crown, and that is too time consuming. So at this point we correct the occlusal plane. As well, and if at all you want to see the section, say you want to mark the curve and see the section, this is of great importance in the mandible because we need to mark the nerve. So if in the mandible you would want to take this plane till the mandibular canal so that you can easily visualize the arch properly. In this scenario, since that is not required, I am going to move on to the next step wherein this is the can alignment. So I think this also has an STL attached with it, and that is why the alignment was asked. So at this point there is a 3-point alignment that is there. This is the merging of the STL and the diaphragm that is there. So as soon as you would come to this step, this is how it would look. You would have your STL in one plane and your diaphragm in another plane. So you go to this, either you go with the alignment mode wherein it aligns it, and then this is the AI generated mode. So if the anatomical structures are well appreciated by the system, both the diaphragm and the STL would snap onto each other immediately. But if they are not, in certain scenarios the intraoral scan or say the lab scan is not of that great of a quality, or the diaphragm is not of good quality, then this would not happen. So you would have to manually align them together with this. So this is a
working on green shows good alignment.
yes. The green, that means it's fully aligned. You have a cross section view also. So you can mark here. So if you see the alignment that is there, that is my diaphragm and this is the STL that is there. So if you see, this is the alignment that is there. So the blue is going to be your STL and the radiographic marking is going to be your diaphragm. So with the alignment that is given, it is almost at the exact position. So you can move this slice cross section and then you can assess it at 3 different points so as to be exactly sure that our diaphragm and STL have merged together.
Follow the contour of the curve.
If there was an
Correct.
error, you will
Yeah,
have 2 teeth.
I will
Right,
show
are
you
they
the error. If you see now,
You can't see the STL line
yeah,
itself.
now we cannot see the STL line, only the diaphragm because the STL and the diaphragm haven't merged together. But with this snap-on now, if you see, the blue outline is my STL. So both are merged together. Now say the AI mode, this merging doesn't take place properly. Then how do we align it? So there is an option for manual alignment, which is a 3-point alignment. So you have your diaphragm on one side and the STL on another, and you take 3 reference points. So 3 reference points that are clearly visible on my diaphragm as well as my STL. So say
So the resolution of this computer is enabling, is causing strain a little bit. Usually it will come out
yeah,
spread out.
it's fully spread so that the left hand side of the entire column is well on one side, then the lower panel is well on one side, and the central work area is well on one side. So it's more easier to focus on these structures. So now we have a marking here. So these 3 points are red, green and blue. Some people in the workflow, what they do is they mark the red point here, then they mark a green point, and then they mark the blue point. And then again, so these are the small tips that are there. What I like to personally do is mark the red point and contralaterally mark the red point that is there on the STL also. Because if you blindly just mark 3 points, then again you have to go back to the STL, keep searching for those points. And then sometimes even the, like previously that 0.1 mm difference also that was there and started blinking red. 0.1 mm distance also in these dots that are there sometimes. Sometimes they will snap on perfectly, but sometimes that distance also will cause some error here that you might end up missing in your compilation that is there or the cross section. And then during the fitting of the guide, it would create a problem. So it is always better to mark the points at the same time. So then I will take, say, the center point here. And always make sure that these 3-point alignments are not in the same plane. Make sure that you mark in 3 different planes, because if you draw them in one straight line, then again it will not reorient it back. So it needs to have some amount of direction or change in the direction, so to go and easily slant between the diatom and the STL. And then I have a ditch here. So now if you see with the marking that I did, do you see that there is still some error? Now my STL and diapom are not coinciding with each other. That means in the pointers that I have marked here, there is some error somewhere, and is why my markings have not gone properly. I'm also having a little difficulty because of the screen configuration, so I'm just going to go ahead with the alignment mode that was already previously generated. So now once we are done with this, then we go ahead, and at this point you can check across at all points and see and finally confirm that okay. Now this also it will ask you twice. This step you confirm here, and then you have to go down here again and put a confirm that okay, my CBCT and STL are merged together. So the system also takes a lot of effort to make sure that no errors happen in the seating of the guide that is there. So once we go ahead and confirm with the alignment, then we move on to the next step. So now my diatom is loaded, my STL is loaded separately, and we've also merged both the data together. So this step is going to be my implant placement step. Now, in this parameter, we check the implant. So you have an implant library that is there here. Based on the available implant, you can go ahead. So I think we only have one library that is downloaded here, but you can go to the software and get all the libraries that are there of the systems that you have currently in your system. Okay. If this is the only system, then this is okay. Then based on the available implants in the facility, you can go ahead and place the implant. So now in this scenario, these are all the implants. So because you are using these implants, we are selecting these, and then we go ahead and place. So at this point also, if I want to measure the width and the height of the CBCT, I can easily do that. And this is for the different windows as for the assessment of the implant alignment. Now we are designing in relation to 1/6. So if you see here, again how in the designing software we have certain balls to make the rotation to move them bodily, same scenario happens here also. So we can move the rotate the implant to whatever angulation we want them to be at. I think the prosthesis was also designed. So I can change the angulation of my implant. The system already has certain safety standards. So like how we say that the distance between the two implant has to be 3 mm, the distance from the implant to the tooth has to be 1.5 mm. So if I were to encroach that, it will point out red. So even at the slightest encroachment, if you see here very clearly, your implant dimension is the one on the inside. The outer green dome that you see is the safety margin. These safety margins can also be changed accordingly. Say I want to keep my distance from the anatomical landmark only as 1. Then I can make those changes in the previous order form itself. However, I would not recommend doing that because it is more safer to work with this.
So here also you can customize safety margin. Let's say you are very short of room and you want to just be 1 millimeter of sinus and not 2 millimeter of sinus. Because that's the okay thing to 2 millimeter of sinus. So here you can set 1.5 2 millimeter apical distance. So if you drop the apical distance, you can actually. So set custom safety zones, put a tick there, it will turn yellow. From green, what the system recommends, it will turn yellow. And then you can drop that, you can see the apex dropping down. In the
outer dome
here you can see 1.77 all the way to 1. That's 2. Similarly, radial distance shrinking. Right? So that's one thing you can do. So I'm going to just keep the classic safety markings on for this.
So once you are happy with this design also, now say with 1/6 we are done, you can at this point go here also and click on the implant to make the changes. So if you want to take the implant here, now again if I am encroaching into the implant position, it says that implant position, implant is in the safety zone. So then again you can work on either of these windows simultaneously and you can go ahead and place the implant. Like I said, you can again rotate the implants, turn the implants, check for the axis. So the central blue line is going to be your central axis line, where your prosthetic screw or any screw into the implant will go into. And once you are happy with the implant position, once this is done, happy with the parallelism, we can go ahead with the sleeve selection. So like I said, in this there is a 4.5 and 5.3 mm. Now the selection of the sleeve will depend on the soft tissue thickness as well as your adjacent teeth. So my placement of the sleeve is going to be in this scenario, because it is a foot supported guide, the sleeve shouldn't go and keep hitting with the adjacent tooth. So then my sleeve height would change accordingly, and so will my offset value also change accordingly. So say if I place a sleeve of 4 into 5.3 dimension, if I have selected that, then we go ahead. Our sleeves are already placed here. You check that it doesn't collide with the adjacent piece. If so, then again you can move the sleeve up or down accordingly. Going down is going to be difficult because if it's colliding at this level itself, going further down again is going to be duplication.
The nozzle will change. And
Yes.
then you have to come.
Then you will have to increase in your drill length. So these are the things that sometimes while designing you understand, and then you have to do certain pre-prosthetic corrections in the mouth. So you can do some amount of enameloplasty on the adjacent tooth, because if the patient's mouth opening is also limited and then you have an offset value of say 12 mm, then it is good. And if you are placing an implant also of say level 11.5, then 11.5 mm implant, and then you have to add 3 mm to it, because your offset values are going to be 9, 10.5 and 12. So with 12 you need to add plus 3 to the implant dimension that is there. So if we are planning on a 10 mm implant and my offset is 12, so then my drill length has to be 10 plus 3, 13 mm. My drill length will be 13 mm. That I think with the picture I had shown. So there are three, when I speak, I am talking about DO in particular. So DO has 3 offset values of 9, 10 and 10.5 and 12. So the jump is 1.5 from the previous one. So 9 say 10.5 is 1.5. 10.5 to 13 is another, 9, 11.5 and 13. So is another 1.5. So when you are placing an implant of 10 and you are going to place you have an offset value of 13, then you will have to add plus 3 mm. So 9 से लेके 13 तक whatever the distance, 9 to 12 whatever the distance was, which is plus 3, that will get added to your drill length to place that 10 mm implant. So if my offset value was 9, then I would only have to add plus 1 and then go ahead with my drill length. So once you are done with the implant position, now in this you can also check the distance between your active implants. You can also check the angulations for placing the another offset value. No, I am not able to move. As soon as I take the cursor there, it vanishes off. So because of the orientation of the screen. That is the length.
And
So
how do
this,
you verify the parallelism? Is there any?
yes, there is one. I was just assessing that. One, you place an implant and then you go ahead. There should be an option for implant parallelism. So there is an option here that says implant parallelism, wherein you place an implant and then you just draw a line towards that implant and in terms of it mirrors that implant's position. However, I do not see that. We just try to change the resolution of the screen as well. कौन सा है इसका? I somehow don't see that option here. However, with these implant measurements only, there is another option here. I will just reconfirm it and I will let you know. So with that, you just snap on between the two implants, and once you place the first implant properly, it would exactly fall on the same curve as the first implant. So that is there. Otherwise, you can take these blue lines as an indication as to the parallelism. Now, if you see, this is slightly going converging towards the second implant. So at this point, if we want to make any corrections to the same, then we can do so at here. Change the implant direction and move it about.
Check for multi-unit angle.
This is that only. So
I think that one option just besides the sleep one. What's that?
no, these are the this is for the parallelism of the implant. This would align both the implants together. I am looking for the multi-unit option as well to assess for the angulation.
Try to change back to the screen for a second to see the options.
There is some issue with the multi-unit assessment. So I just check with our system also once and then let you know how that is to be
I
assessed.
actually wanted to discuss a case with you
Uh,
where we would be requiring multiple.
okay. If you could post this, just give us 5 minutes, we'll just get back to you. So with the parallelism, if I want to keep the 1,5 based on 1,6, then I would just select this. On clicking of that, the 1,5 would go and become similar parallel to that, and the parallelism would get attached. So any changes that I would make to one implant, that would immediately be coming onto the next implant. So both the implants now are parallel to each other, and that is how any changes made on one would impact the changes that are on the other. Now if you see here this yellow, that means the C's are colliding at some point. So if you go ahead and move them, that should get alright. Then you move on to the next step. So this will come up to the surgical guide creation. Now since the guide was already created, I'm going to delete that. So at this point now, to mark the surgical guide extent, you again take the plus sign and then you do the marking for the guide. So it can extend to the adjacent tooth, 2 to 3 teeth at least, and keep 1/2 of the proximal area of the tooth visible so that you can assess the fit. Another way to assess the fit is also creation of the windows that are there. So with the window creation, there is this option called as bars and window. In this, there are certain support bars and viewing windows that can be placed. So if we were doing a cross-arch stabilization, we would be placing a support bar to assist in the cross-arch stabilization. For a viewing window, this is where on the guide should have. So in this also you can change the width of the window that is there, and then you can assess. It is always ideal to have one on the buccal aspect and one on the occlusal surface so that we can easily assess the with that the placement of the guide that is there. Yesterday we had shown a case wherein we had done a sinus lift using a guided window. So in that, based on the planning that is there, you make a marking where your antral vessels are, or your, say if there is a septum and you want to create 2 separate windows for the sinus lift. Once that is done, a same viewing window only can be placed onto the buccal aspect here, and then it can be continued. There is some glitch that is happening on the software right now, because at this point after the surgical guide creation, once you move on to the bar and window step, if you had seen in the previous video, once you finish this step, a white color guide will already be generated. And then when you place the bar and window is where your, on the guide the windows would collapse. So say if I were placing a window here, I will change the angulation. The next step is a ID tag. Yeah, I don't know. This is the name. So this can again go onto the palatal surface or onto the buccal surface. This can be placed, and then these photo tags can also be moved around. The name changes and all that can appear here. How you want the details to appear can also appear. How you want the alphabets to appear from here, whether you want it to be embossed or you want it to get engraved. So these are all the options that are there. And at some point, don't know why this is coming because they already say all the time. So this is how it comes. Here I will place it here. So at this point, you can see the surgical report. This is before you save the file. You go ahead and see the surgical report. You check whether the placement in 1516 is correct, whether the implant dimensions are right. And then you go ahead and check the final placement here. Check the implant positions. And if you see here, the bone ranges from D1 to D2. You have gray areas, you have green and blue areas. That means the D1 to D2 quality of bone. And it lies somewhere here. Black bone is immature bone. Avoid placing implants in immature bone. Anywhere close to D2, D3 is the type of bone implant content that would be ideal for the implants. So that was for 1.5. This is for 1.6. This is the surgical report. So you can keep this in your, you can save this and like Sir said, as an activity for all your students, this can be started. Once you are happy with this, then we go ahead and approve the plan and then you can go ahead. But at this step, however, a guide should have already been ready by now. I do not see a guide here. So this could also be because of the reason that a design was already created and we changed the order form and reworked on the design. So certain parameters and errors could be there on this. If you have just the STS and the diagram,
I think it was 1516 and 27 also you had marked in the order form, right?
no, they had marked all the tape.
Oh, okay.
They had marked the entire upper arch. So that's why this error could also be because of duplicate design.
So when you do a fresh design for a case, the guide should have appeared. So if once the guide appears, then you can tag it. And once the guide appears, then you can use the window tagging for corrections. So if you have a sinus lift case also, the window itself will become an empty space. You can access through that area.
But for a sinus lift case where you would want to make a window, this cast scan would not suffice because the extent is not till there. So no matter what, I will not be able to take my guide to that region because I do not have the STL of the data that is there.
Full max. There's always intraorbital margin.
Correct.
And then we extend the guide onto that area.
Correct.
That's when we'll be able to
Not
see
till the intraorbital margin, but just till the sulcus or the vestibular depth. Yeah.
If you record the full depth of the sulcus with the retractor nicely retracted and your STL, CBCT will extend fully. That's not a problem. So with your FOV you will be able to capture from sinus till mandible.
How about the STL?
STL you have to retract with the retractor and make sure to tag that area. Second option,
The sulcus depth vibrity
yes,
scan.
yes, you have to get all the sulcus depth. Second option, if you're not able to get, let's say a patient is there who has difficulty in sulcus depth recording with your scans, buccal mucosa is not allowing, take a good azurite impression with a thick azurite material which will push to the sulcus a little bit. That will give you the adaptation of what you do. Anyway, the guide will go on to the bone. So you just need a rough surface onto the soft tissue. It may not be perfectly adapted onto the soft tissue, but it will be available to the bone.
How to make it prosthetically driven? Like, can
So that's what I said. At this point, the crown is already designed.
So they have already
Okay. The crown is already. Let me go
made
back.
the guide.
No, because the crowns were there, na, initially, so that was already written. So at this point, the crowns are already designed. So because this is a redesign of an entirely changed order form, there are a lot of steps in the system only that it has negated and has gone ahead with the planning. After this
So
step,
if
once
you
you
want
load
to-
your
So if you want to do the prosthetic planning, the waxer part, no, that is your tooth part that is designed, the blue color that is designed, you have to position it in the right place.
there is an issue in the file only. Because we've changed the order form, this is what normally happens with the system. So when you go ahead and keep designing on the same STL and the diagram that is there, or you keep modifying it, it will crash at some point and it will keep showing some error. Or no matter if you end up finishing the design also, your final STL of the guide or the
not just pertaining to the guide, but to the crown, to the bridges, to any FPD designing also, that error will keep happening.
If we need to modify, what should be the SOP?
You go back again, create a new order form,
Delete that order form.
yeah, go ahead and
Don't re-edit in that same order form itself. Second thing sir was asking how to process
Next step is will come.
So when you start scheduling your position of the implant and all, before positioning the implant itself, you will have a idea where you can position your teeth. That is the blue part that is going to accept. So once you position your teeth, then your implant will come through. Now since you want the implant access to open right from close to the teeth, you want to make sure that there's no buccal overlap. So you make sure that the long axis like this. So you see that the blue line, we shall get rid of the CCC.
I'm not able to get this.
So-
I'm pressing something
Okay.
else on the other.
CCC must not CCC can put a take off.
The cross option is here.
Okay, get the sleeve.
Wait, wait, wait.
Sleeve mode. Yeah. So you can see the long axis of that implant, right? Occlusal. That's where it will open up.
Now in the
Understood.
designing also, I think because the initial extraction socket was not done properly. So if you see this blue is also at the root stump level
Part
only.
of it is still there.
Yeah, so the extraction, now because we've gone ahead and redone everything, the system somewhere I think has not caught up to the redoing
You
and
had
that we have
deleted it,
done.
it's showing it.
Sorry?
You had deleted it, it's still showing it.
Correct, we had deleted it, but that is what happens when the entire process has to be repeated. If you had seen the denture also at one point it kept showing the boundary error. So then I had to go back, read the form again and redo the design.
So thank you so much, Dr. Nabil and Dr. Kushal. It's been a very, very informative 2 days, sort of an eye-opener, I think, for all the faculty and students here. And we have a lot to catch up with you people. Thank you so much. I now request our respected Director Principal Sir to acknowledge the resource faculty for this workshop by presenting a small memento from our side. So, Dr. Nabil Ahmed. Amazing 2 days.
So
Yes, definitely.
happy. We'll be very happy for you to visit. So one thing I would like to say, as from Savita and from us as well, this doesn't end here. So you can please reach out to us anytime. So if you have an issue somewhere,
So if you don't mind, Dr. Nabil, can we add you to a WhatsApp group in like a digital workshop, and we'll add some one faculty from each department, and maybe I think we will have a lot of questions which you really, if you stay there for a week, you will not be able to cover. So we can have a back and forth.
so what we can do from our side is we can add our people also to the group, so that see, I do mostly of the technical aspect of it, and I'm doing the education part of it. We have a designer for tool supported, we have an implant supported, and we can add you a link to that group. And over the next 1 or 2 months, you can post in your questions and we can help you handle that. One solution that what we do from our side is we also have a 3-shape person who is our resource person, and we have all our faculty and the 3-shape person also in that group. So you can actually insist. So the companies, once they provide you the stuff, they usually try to get back. That's it. We are giving you stuff. But actually, if you insist, they will come and give you all the technical support you need. So through our entire course of our lockdown, we had webinars from 3Shape. So our PGs were all fully engaged. We didn't have time to lose that time. So since we were not able to go to clinics, since we were not able to do our patient work, we ended up doing something like this. So you have and one advantage is it can be in the non-academic time. It can be like from 6 to 7. Because someone from Mumbai or Delhi, Mumbai or somewhere will be on the system and he'll be showing you in the screen. So it will be a Zoom meeting or something, so you can easily ask a question. So that's what we do. Similarly, we can plan something from our side. Out of the limited resources that we have in our minds, we can help you out with that.
Sure.
Thank you so much. Sham.
Yes, sir. Ma'am, the video. Sorry.
A small feedback from our side is that you have a lot of young staff and you have a lot of guidance here. There's like a good mix of experience and involvement as well here. So I think that's how you need to section it out. Like that's like even in the cricket team, that's my baby. So one good thing on your side is you already have experience and you already have thrilled young staff. Because yesterday people came up on to us and they were asking for things that some of it we have to look up on our own homework. So that involvement will actually take your leaps and bounds. So that's one thing is an advantage. So try to match to that advantage. Involve a lot of young staff in the technical part. We can give the guidance on that. So that's one thing and that's one way to look at it. Thank you so much. I had a very good time here. Very interactive. We never wanted to be a monotonous lecture. We wanted it to be a multi-sided discussion, which we ended up having. And okay, I love you. So after this lunch session, we'll probably have a visit to your digital upcoming clinic and give you inputs on that. And we are not closed from today. We are open for a long time from now. As much as long as we keep teaching, we'll definitely be open to answering your questions. And that should be the order from our side. Thank you so much.
Thank you, Dr. Naveen and Tushari, for this entire experience for our young faculty. You said it right, extremely young faculty. It's a mix of young and old, but generally it's on the younger side. So there's a lot of learning curve which is there, and this is something which we planned. And I thank you for being a part of this officially to just put it on record. And I would like you all to also appreciate Dr. Payal's efforts, tremendous efforts he's taken to get this entire program in place. He has been the mediator for this entire thing, and Payal, being one of the senior most faculties of our college, has taken everything together and put it into place. We needed somebody to get the juggernaut moving, and she has done the right thing. I hope she'll see that it continues in the future. Thank you.
Small note I wanted to add on here is that in between this program was supposed to be in the end of November, and I had a small health issue, but ma'am was persistent on like, okay fine, are you okay now, can you make sure to have it in the next month, middle of these dates. So it kept us pushing. So at some point I thought, okay, maybe I'm not going to be alright for a while to travel and all, but I think that her motivation and her insistence for us to come here, that has actually gamed up. So we put extra effort for this presentation and we worked around your own systems on what you have and how to get that better. So that's one thing. Thank you, ma'am, for having us here. We really appreciate yeah, actually you need a certificate for organizing.
Come, we'll take a photo together with guests. Acknowledge Dr. Payal from our audience. This is for you, please. No, this is ours, but this is ours. Thank you. So we'll meet up after lunch. Yes, sir. We have a file to show you. I'll also do that. Yes, sir. Yeah, half an hour. It took 10 years to complete.